So what I wanted to do for my final lecture was to share with you some challenging and instructional cases. And a lot of these were lessons learned at our institution, and I wanted to make this interactive as well. My only disclosure, consultant for in vitro, has nothing to do with this talk. So hopefully I can show you some challenging and instructional PET-CT cases. So the first case I wanted to show you, and this will highlight the differences between fluciclovine and PSMA. This is a patient that had prostate cancer treated initially with chemotherapy and radiation and prostatectomy. And he had radiation, you can see, to the sacrum and lower lumbar spine. His PSA at this time was 3. It went from undetectable to 3. This is a couple years ago. We could not find definitive site of disease in this patient on this Accredited study. So this patient was treated with chemotherapy, and he did well. And then this is one of our first PSMA PETs that we did at our institution. Now, unfortunately, his PSA went up from 0 to 1. At the Accredited, it was at 3. So you can see the differences in sensitivity. We're seeing 2 lymph nodes with a PSA of 1, which we didn't see at all when this PSA was higher. This also illustrates the differences between these 2 radiopharmaceuticals. You have a lot more background activity with the fluciclovine, which you do not have with the PSMA. The only advantage that fluciclovine has is the fact that because you're imaging right after injection, you inject the radiopharmaceutical while the patient's on the scanner, you don't have bladder activity as a possible confounding factor. So if the patient still has the prostate, or if you're looking for recurrence at the prostatectomy site, you may potentially have a better chance with fluciclovine than PSMA for that. But this PSMA has much higher sensitivity. And also in the case that Dr. Wang had showed with the ureter, you're not going to see ureteral activity, usually with fluciclovine, just because you're imaging so early on. So you're not going to have, you're not going to mistake ureteral activity with a lymph node, as the case that he showed. So I just want to show you these 2 areas. Again, this is the PSMA, this is the fluciclovine. Here's one of the lymph nodes that is positive. I'm going to kind of blow this up here so we can see it better. So here's this lymph node on the fused image, and you may think that this is a ginormous lymph node that we're seeing. This is the same lymph node here. I'm going to take away the fusion. It's a tiny lymph node, sub-centimeter. It has not changed from here. We were not able to call this disease at this time. I'm sure it's most likely that this was involved at the time when the PSA was high at this time. Here's another lymph node. Again, it's very small, and again, it was not positive on the fluciclovine. So it really shows where we are and how the advances have been made. And our GU oncologists are so excited that we're offering PSMA imaging. This is not a patient who's going to be a candidate for PSMA therapy. He's too early on in the disease, but this is dramatically going to change his treatment, because now we know where the lymph nodes are positive. He's going to get radiation, local radiation to those sites of disease as his treatment plan.